Good morning, everybody. At the outset, thank you, ma'am, for giving me this opportunity. So after such a beautiful presentation, knowing about what and where, now let's see what are the ophthalmic manifestations and assessment in children with CVI. By now, we know it is a true visual impairment, which includes both cortical and subcortical level of brain. But why is it important to know the features of CVI? Because these visual malfunctions can be easily overcome by simple environmental measures and can help the child to be a part of mainstream and help to perform academically and socially well. So in the next few slides, I would be taking through some red flags of how to assess a CVI child as he presents to our OPD. CVI, the functional behavioral deficits, a few pointers towards it, and to evaluate as an ophthalmologist the tools what we need at our end, and to reiterate how is CVI different from OVI, which is ocular visual impairment. So at birth, if a child comes to us and by 2 months, if there has been no eye contact, doesn't make unstable eye contact, that should cause an alarming thing in us. Apart from that, by 3 to 4 months, if there's no social smile or no awareness of hands, doesn't want to explore his or her own hand without that, there must be that these are few features by within 3 to 4 months, which must be known that the child is developed having a mild developmental issues by 3 months. Now by 5 months, if there is squinting, or by 6 to 7 months, the child is not reaching out for any object, not recognizing faces, not even familiar faces, not even the caretaker or mother's face, that means that these child are on the course of a developmental delay. By 1.5 years, if the child cannot put small objects in a container, does not point finger when named, or does not respond to mother's gestures, that means these child are again need to be evaluated thoroughly, and also the parents need to be educated. By 2 years, if they cannot scribble, do not walk steadily, or do not understand simple commands, and by 3 years, if they have trouble climbing up, down down from steps as discussed, or does not communicate meaningfully, continuous drooling, or even cannot eat without help. These are a couple of signs which each of us must know when we see a child presenting to our OPD to assess whether the developmental course is normal or leading to a delay. Now we have seen that as the child has presented, those are the milestones which were affected. However, we just saw that there is a dorsal and ventral stream which is affected. So what has been discussed are there are 16 areas of visual behavior affected in these children. A child may have subnormal vision, may have normal vision, but still would have some of these problems, one or the other, specific to each child, which we must assess and know that what is specific to each child, so that accordingly measures are given. Now coming to visual attention, they would have poor fixation, they would have difficulty in shifting gazes, hence bumping into objects. Visual recognition, it would be difficult for them to identify faces, to recognize people, or even objects. They may be seeing, but they will not be able to comprehend what they're seeing, what the object is there in their hand. Impact of clutter is huge. As discussed, they will not perform well when the background is cluttered. They need a clean environment with less number of objects, and that is how they will not see. They will not perceive multiple objects in one scene, so causing simultagnosia. If there are multiple objects, they will think that it is only one image. Visual field abilities, they would have both peripheral and central field difficulties, which would impair their visuomotor coordination. Mostly it is known that is inferior field which is affected. However, children would only prefer right gaze or only prefer left gaze also, and that would be their gaze of preference, and they would try to look into that side also. Now color, they would always prefer solid colors, no patterns or no clumsy thing. Form accessibility is there, where they cannot identify the exact form of different objects. Given a cup is given to them, they will identify their own cup, but a similar cup given to them, they will not identify their borders. They would have their own coding strategies to identify the objects. Visual guidance of upper limbs and lower limbs are hand-eye coordination or walking or crawling to take an object. Access to people, as I discussed, is the familiarity with the faces. Impact of light. This is a dual mechanism. Now, some of the CVI children would just light gaze and watch towards light, liking light so much so that they want their rooms to be brightened up or shiny, whereas others would have photophobia, which will induce in them a visual fatigue, that they would prefer remaining in darker rooms and will not want to go out on a sunny day. Response interval is latency or reaction time. Given an situation, they would take time to react to that situation. However, if they know that it is a familiar one or it is object of their choice, their reaction time will be quite short. Impact of motion. This is again something which is dual. Some people, some CVI children would prefer moving objects, and some would only want to look up at a static scenario. Sensory integration, their performance is affected by vibration, by touch, all of these things, where they always want to be like isolated and would want to run away from crowded scenes. Visual curiosity, they have decreased nature for exploring things. And coming to appearance of eyes and movement of eyes is strabismus, nystagmus, gaze palsy, as we discussed, saccadic palsy, which will be very common in these children. But now we should be knowing all of these because we are wanting to evaluate these children in a normal scenario. So what Dutton says is, society chooses to present information in a way that majority of the people can see clearly by ensuring that it fails within these normal limitations. Now, this is someone who is a teacher in visual impairment, Mark Chazin, who says individuals with CVI actually spend their day in a world which is designed for someone else, and hence we should know that each of these functions are very, very important in each CVI child which we would be seeing. Now, but how is it done, functional assessment? Do we know how to quantify this? A quantification is necessary for all these children, so to choose our measure and see how they improve subsequently. Roman Lanzi has described this as a parameter called CVI range, which has scores from 1 to 10, which focuses on these 10 things: that color preference, need for movement, visual latency, visual field preferences, difficulty with visual complexity, need for light, with distance viewing or atypical visual reflexes, and visual novelty and absence of visually guided reach. Out of those 16, these are the 10 major parameters which is being focused. And these are some screenshots of the CVI range questionnaire, which is taken by either by observing, not either, it is by observing the child, also by interviewing regarding the child's behavior, and taking observe, and also through a direct contact with the child, that is assessing the child in your clinic as it comes. Now, R is something where it represents a resolved visual behavior, whereas plus describes the current functioning of the child at what status he is. Partially describes student, the child, is plus minus, where, and if it is not applicable, it is minus. The score ranges from 1 to 10, and there are different questions which we can assess both before your measure is initiated and after your measure is initiated. Now, coming on to what are the ocular manifestations as a child comes, we know that there is a visual impairment. Parents will bring them. The child is not looking to our faces, but there's always a need for light. The child would only be doing light gazing, attracted to bright primary sources, or would have a non-purposeful gaze when looking at even interesting targets. So apart from visual impairment, these children may have white reflex, deviation of eyeballs, shaking of eyes. So here we come that there is CVI and OVI which is interlapsed, but still the CVI has to be taken care of, because despite treating the OVI or the ocular visual impairment, children will not perform better. So as we begin to evaluate them, what we need is good fixation targets. First, after seeing the child, one can assess that what is the visual sphere of the child, till what distance or within the room does he prefers, and then we should choose targets which would be like puppet faces, because the child begins to see the mother's face, and mother's face would have discrete features. So a puppet faces is a very good target to assess child in the OPD. Third, one should wear dark or a solid shade of apron, or even remove your apron to stop the fear, and the room should be clutter free. Assessment of visual acuity can be done using charts like Lia paddle, stellar acuity, Cardiff, which are preferential based, or OK and dumb in very poorly responsive children can just elicit a nystagmus and tell us about the visual prognosis. Sweep VEP is very useful because Sweep VEP performs within a span of 10 seconds, multiple readings are taken, and we know these children have a short attention span. Coming on to assessment of visual acuity, these are for your videos which shows how a Lia paddle is used, which has one diffuse background and one stripe background. Now the width of the stripes increases as you see the child focusing on the wider ones. Then you can take another slide which would have, or a paddle which would have a smaller width. This can be done both binocularly and then also monocularly. The age of the child in months equals to expected grating acuity in cycles per degree. The quantification is again given on these Lia paddles behind them. Refraction is very essential to do a static retinoscopy as in any child. A cycloplegic refraction where homatropine is the cycloplegic agent for choice, and a near retinoscopy is also done because most of them would also have accommodation issues. RAF ruler can be used in older children, a dynamic retinoscopy and MEM can be done to know that how much is the accommodation lead or lag in these children. Also in OPDs we could have glasses made of +3 and +5 or +4 to see whether their visual performance significantly improves after putting on these glasses, so that we know that they prefer the near dominant sphere. Now, what is known in literature is in preterms, myopia and its association is, myopia is common with its association in ROP, but children who have escaped PVL who are born after 28 weeks, hypermetropia is more common. Children with cerebral palsy also have hypermetropia, and all of those children would have some amount of accommodation insufficiency. This was a study published from our institute, where we found that simple myopic astigmatism and compound myopic astigmatism are the most common refractive errors noted in Indian children. Coming on to field defects, they would have lower visual field impairment, tripping over things on the floor and difficulty walking downstairs. Visual field preferences would be there. They would have inferior field defects mainly because of superior periventricular damage, and also some of them would have right homonymous hemianopia. For assessing this, older children, we can do Humphrey, or a confrontation testing can be done in any child even if they are smaller. I'll show you in the next video. And for so a puppet facies again can be used, or a small toy with a cardboard as a partition between, and binocularly seeing where the child is fixing as you are moving the toy. Otherwise, the toy can also be the initial part is like explaining the procedure to this child and then making the child do it himself and choose watching for which is the gaze which the child prefers. Leah wand is another modality which is available, which has an illumination at the top, and it's a mobile wand which can be moved to any direction and move based on the gaze to which the child moves. The field can be appreciated. Color vision. Now, most of these children, color vision is usually preserved. They would have very poor vision. However, they will identify the color of the suit you are wearing in the OPD. Children often have a favorite color and will only look at certain colors, preferably red and yellow, because they have longer wavelengths. Now, contrast is essential in all these children, because in the room it has to be with good contrast, where they would appreciate the faces. Leah has described the low contrast symbols, the grating test, and the hiding height is another one which has been proven in literature to be equally with positive correlation with Pelly-Robson. As we do the contrast, this has contrast from 25 to 100%, and these charts can be swapped one after the other, which will also tell that either they prefer motion or they prefer static things. Pursuit and saccades are also affected, where there can be dysmetric saccades, or there can be initiation saccadic paralysis as seen in oculomotor apraxia. Coming on to strabismus, they would have esotropia, which is the most common type of strabismus noted, exo, but the characteristic pattern is the dyskinetic strabismus, which changes on momentary basis, or the angle variability and the shifting pattern. Neuro-ophthalmologically, when we evaluate the fundus, children who are born less than 28 weeks have smaller discs with nerve hypoplasia. However, after 28 weeks, those who are born would have pseudoglacomatous discs. If there is a subcortical lesion, the children would prefer tonic downgaze, nystagmus may or may not be present. Most commonly, esotropia and large discs are seen. Now, to revise, how is CVI different from OVI? We know that OVI, if we would explain the visual behavior, whereas CVI will not describe that. In most of them, they would have prolonged latency for visual response. The attention span is poor. They have difficulty with crowded scenarios. Light gazing behavior is present, and color is usually preserved. Unlike in OVI, the color may be affected based on the neuropathy or maculopathy. Now, these are two simple tests which can be done to distinguish OVI from CVI. Now, these are tests which has taken into consideration so many things, that is orientation of the child, the mobility, the hand-eye coordination, the colors, and the latency. So, as we see, the chosen colors are discrete colors, they are good solid shapes, and the child is asked to see those shapes and fit into the exact boxes in the above one, which is a Leah puzzle, whereas in the Leah mailbox, the child, it will give us a reflection of the perception of the child, how the child is first orienting the postcard before he puts it into the slit. A CVI children will have difficulty in performing these. Thus, we know in CVI, the brain is overloaded. And what Perkins says is, each of this child is teachable, and every child has a right to meaningful and accessible education. These are some of our children of CVI who have been thoroughly rehabilitated and now can paint and are also going to school. Thank you.
Thank you, Soveeta, for an excellent presentation. Any questions before we start the next session? So I know assessing CVI children is the most difficult. So any questions like what do we need is basically we need a LIA paddle chart in the OPD. So that could be used to assess the vision. And the children who have no eye contact or in CVI range 1 or 2 where the child does not focus on anything, so we measure the CVI range. So we have a early intervention specialist who measures the CVI range, and how she explained the CVI range to measure, and then she will start doing the early intervention exercises. So when it is 0, so when the child presents with 1 or 2 means the child has no eye contact, not able to reach out to objects, not having any eye tracking or scanning, those children we will require to measure the CVI range, and then it is a work of the early intervention specialist. When the child starts tracking, scanning, and then we find that the child is able to see, then we can measure it with the LIA pedals, or we can go ahead with the TAC. And it's important to measure the contrast. So what I would advise that whenever we are going for, because what we found in our study that 31% of our preterm children had CVI. So maybe we could give a referral card. So whenever we are going, most of us go for the ROP screening. So maybe you can tell the parents that if these are the red flags, and if the child is not, say after 2 months or 3 months, there's no eye contact or not able to focus on any object, I think they should be referred to a pediatric ophthalmologist so that we can intervene early. Because when you intervene early, what I've seen is that a CVI range of 1 and 2 can easily become 8 within 3 or 4 months if we intervene before the age of 6 months. So they really improve. So, but the thing is that they have to come to you. So this is awareness I think we all have to do, and we need to create so that because we can treat them early. So very nicely she has documented all, and I don't think we need a lot of money or things to invest for this. Time, yes. So we could train an optometrist, see, because who is really interested, and time, because because they do take a lot of time to even do that simple test of LIA mailbox and LIA puzzle. It takes time. So we could have one optometrist trained for this. Not necessarily to be a neuro-optometrist, it can be a normal optometrist who can do. And of course we also need to do a lot of, because we have to spend time on refraction. We need to have an optometrist who's specialized in doing MEM. So basically we'll need a good optometrist who knows all these techniques, and then we can intervene. So glasses also is important, how we give them glasses. So so any more? So yes, time is a factor, but yes, we need to help these children.
I wanted to ask that they have variability in attention spans, right? So how many times do you all do like this assessment? Because it could be like a phase where they are not so attentive right now, when you've taken an assessment, and then we're taking it later. So how frequently do we assess them on the scale? And if we don't get a good response initially, do we reassess it?
Yeah. Because sometimes we need that. That is a very important question, because sometimes even when we send to the early intervention specialist, because they need to assess the latency, how much it is improved. Like whether now they're looking at a particular object, and whether now they can see it very soon, or they take a lot of time to see it. So that latency is also covered in the CVI range. So inattention and latency is covered, like to look at an object. So they will make the patient wait. So it's a 1 hour appointment with the early intervention specialist. So because we give a 1 hour. And so if there is inattention, then we keep repeating the test till we get a proper test. Now strabismus assessment we'll discuss later, because that is when we have coming to that's more difficult. But what Soveeta has presented is vision assessment. So vision assessment only after they have started tracking and scanning and their attention has improved, you find that like by uniocularly assessing by LIA pedal is practically impossible in these children. So it is not possible at all. So you are assessing their refraction and seeing whether there is anything in amblyogenic in both eyes. So then you can advise patching, or you are seeing if there's any squint, and that's how you are advising patching for treatment for amblyopia. Otherwise, vision assessment uniocularly is very tough. Binocularly, yes, they are cooperative, but we need to, as Dr. Soumita was saying, we need time for assessing these children.